We know, of course, that in real life, overexposure to radiation causes harm, and radiation safety is an important issue that needs to be constantly discussed.
I'm BienSoo from the Department of Vascular and Interventional Radiology at Singapore General Hospital.
Join me as I discuss a personal perspective on radiation safety in interventional radiology. I would like to thank the AOSR and the IAEA for inviting me to share my perspective on radiation safety in interventional radiology at this ASIASAFE program. I note that the ASIASAFE website is a rich resource for radiation safety regulations and codes in the Asia-Oceania region. Specifically for interventional radiology, there are 3 excellent publications, 2 published jointly by the Society of Interventional Radiology and the Cardiovascular and Interventional Radiology Society of Europe, and the International Commission on Radiation Protection has in 2018 published this document on occupational radiological protection in interventional procedures. Let me briefly go through them. This guideline for patient radiation dose management in interventional radiology, published in 2009, covers the scope that includes pre-procedural planning. The document covers the need for individual training of operators, not only for initial training, but also for annual refresher training. It also discusses equipment and the need to disclose and explain to patients that radiation is used for their procedure and the need for consent. Intra-procedurally, monitoring of radiation dose should be performed and operators notified when certain levels are reached. If dose is not available, then at least the exposure time is monitored. Dose minimization techniques are also discussed. After the procedure, there should be documentation of dose to the patient, and there should be follow-up if required. This next publication in 2010 addressed occupational radiation protection. It discusses the dose limits recommended by ICRP and also the number, type, and location of personal dosimeters. Shielding in the procedure room, as shown by ceiling suspended shields, tableside lead drapes, and movable lead shields, as shown in these images. Personal protective devices are also discussed, including the need for proper aprons, thyroid shields, and protective eyewear. There's also a list of practical points, as shown in this list, which encompasses the ALARA principle with time, distance, and shielding. This table shows the percentage of dose reduction that can be achieved with these good practices. ICRP 139 is an excellent and comprehensive document for interventional radiology, as you can see from the contents on the right. If you have not referred to this document, I strongly encourage you to read it and use it. What is new in ICRP 139? It discusses the new recommendations for the dose limit for the eye lens, which has been lowered to 20 millisieverts per year. I will discuss the reason for this later. It also mentions that assessment of the dose to the hands should be further studied, and that new interventions involving PET and selective internal radiation therapy pose different challenges. There are also nice diagrams of the distribution of scattered radiation during fluoroscopy and how it changes when oblique views are utilized. I found these diagrams for different accesses during interventions to be also very educational. Similar to fluoroscopy, awareness of the scatter distribution during CT interventions when the operator is in the room utilizing CT fluoroscopy is critical. Here is the distribution of scatter during CT, and this is why operators are advised to stand just at the side of the gantry during CT fluoroscopy acquisition. Personally, I always utilize intermittent CT fluoroscopy for my CT interventions and not real time while guiding needles and probes. You may now be asking, if there are such comprehensive guidelines in existence, why are we still talking about it? Here is a recent survey published in 2021, and you can see from this bar chart the red segments indicating that operators never utilize eye protection are still quite substantial. Similarly, ceiling suspended shields, tableside drapes, and over-table shields are still not fully adopted. Why is this so? Here is the growth forecast for interventional radiology till 2028, and interventional radiology is forecast to grow by 5.6% annually, with an annual market value of more than US $36 billion by 2028. Due to the success of radiological guidance facilitating minimally invasive treatments, procedures have become more complex with the use of multiple imaging modalities, resulting in increased radiation exposure during these complex procedures. As a result, despite technological advances to reduce radiation, like pulse fluoroscopy, it is felt that these techniques will not reduce net radiation dose as procedures become longer and the number of procedures continue to increase. Let's briefly discuss radiation injury to the eye. We know that radiation exposure leads to lens opacification and that the severity increases with dose, and the latency is inversely proportional to dose. The RELIT study showed that up to 50% of interventionists had posterior subcapsular injuries when compared to a control group with only 10%. ICRP 139 thus recommends routine use of ceiling suspended shields, proper protective eyeglasses, and the use of 2 personal dosimeters, one of which should be unshielded over the apron at the collar. I'm embarrassed to admit that in my country, this has yet to date not been implemented. What does it take, therefore, to build a radiation safety culture and habitualize good practices? We have to include the stakeholders, which encompasses both the organization and the individual. At the organizational level, it is imperative that there are established guidelines and protocols and resources to enable the provision of infrastructure, equipment, and personnel for radiation safety. The organization should provide ongoing training, and there must be a robust quality assurance program. Last but not least, strong leadership support is critical. What about the individual level? I'm sure many of you are familiar with this book, The Checklist Manifesto by Dr. Atul Gawande, who pioneered the concept of time out before surgery. In his book, Dr. Gawande wrote about what it means to be a professional. He mentions that all learned professions, for example, medicine, have a definition of professionalism, a code of conduct, where ideals and duties are defined. First is an expectation of selflessness. We place the needs of others above our own. Second is an expectation of skill, that we aim for excellence in knowledge and expertise. And that's why you all are attending a session like this today. Third is an expectation of trustworthiness. However, he stated that we in medicine fall far behind the airline industry. Aviators add a fourth expectation: discipline. Discipline in following prudent procedure and in functioning with others. He goes on to state that discipline is hard, perhaps harder than the above three, as we as humans are not built for discipline. However, to be a true professional, discipline is something we as individuals have to work on. Dr. Claire Cousins, the immediate past chair of ICRP, also acknowledged that it takes discipline to constantly remember to don all the appropriate radiation protection attire. But if we habitualize it, do it all the time, like wearing a seatbelt in a car, then it will not be difficult. In conclusion, these are the take-home points of my perspective on radiation safety. Comprehensive guidelines and protocols are freely available and should be adapted to be fit for purpose. Both the organization and the individual have key roles in creating a radiation safety culture. As radiologists, we have a moral obligation to be the radiation safety advocate for our patients. Thank you very much for your attention.